bloomberg Data for Health initiative has been supporting the Ministry of Health, as you know. I think I'm talking to the converted because you are all involved in this, but just in case there are those that may not be aware. This data policy program has been a Ministry of Health initiative supported by the bloomberg Data for Health initiative. And since the development of the policy briefs, which is part of this program and part of the knowledge translation program of the Ministry of Health, the Ministry of Health decided that they hand over the program to the National Health Research Authority. The reason being that the National Health Research Authority has a mandate of knowledge translation. So they decided that they will hand over this, and that function was handed over to the National Health Research Authority to act on behalf of the Ministry of Health to coordinate that program. And as you know, the Data to Policy program is a hands-on training program where the participants go through an online course on gathering data and the tools of analyzing that particular data, and then we, at the end, present a policy brief like what is going to happen now. There's also an in-class training and an actual development of the briefs with the trainers who are referred to as mentors, and we have a number of them in the audience. Then after the in-class sessions, the participants are continuously linked to the mentors who continue to coach them as they keep on working on the policy briefs, and then involve different stakeholders until the briefs are in a position to be presented like they are going to do now. Then, as you all know, those of you who have been involved in developing policy briefs, developing a policy brief is an iterative process. It's an on and off until you perfect it. So it's an iterative process that ensures involvement of different stakeholders at different levels. Policy briefs are a very important tool in evidence-based decision making because they make a model as they give the policymakers a picture of the cost and the benefit of choosing specific options or policy options. What I wanted you to know is that the National Health Research Authority, as part of its mandate of knowledge translation, has set up what we're calling a knowledge translation platform. And I wanted to mention that this Data to Policy initiative has been incorporated to be part of that knowledge translation platform. So, the knowledge translation platform is just not about forming or developing policy briefs. Because once you have developed a policy brief, your idea is to make sure that it is incorporated or translated into an actual policy. That means you don't end up like what we're doing now, we present and it ends there. There is an advocacy component that you have to carry out to convince the policymakers that they should adopt that option. And that's why I wanted the peers to be here and so on, but I know that you're very passionate about this. So the component of advocacy is extremely important. So I do hope that even as you make the presentations, you will also be able to make sure that you have the skills to do that advocacy. And it is one of those things we want to do as part of the knowledge translation platform, to train in advocacy skills, so that you don't end up just making that policy brief and presenting it, but you have the skill to engage into policy dialogues, so that at the end of it, those policy briefs are actually translated into policies. So with those, since we are behind time, with those few remarks, I just want to welcome you and hope that you enjoy this session. and hope that you'll be able to participate. Thank you so much.
What the HEP is going on, protecting future generations, addressing hepatitis B among newborns in Zambia. So those are my mentors and my colleagues. So as we all know that hepatitis B remains a major public health concern worldwide, with over 257 million people infected, and sub-Saharan Africa bears the substantial burden with a prevalence of 6.1%. With this prevalence of 6.1%, we know that there are variations from country to country and region to region. And over 887,000 deaths have resulted as a result of hepatitis B. In Zambia, our overall prevalence stands at 3.5%, that is in the ages 0 to 59 years old, which translates to approximately 896,000 Zambians infected with hepatitis B. The prevalence among pregnant women stands at 6.5%, and hepatitis B remains a major cause of cirrhosis and also contributes to about 50% of cases of liver cancer. Hepatitis B is further responsible for most of the mortality in persons with liver diseases, and the overall risk among adults, the overall risk for chronicity among adults is about 5%, but the risk for chronic infection is higher in infections which are acquired at birth. Most of the people who are infected, usually they may be without symptoms and they may not know that they have hepatitis B. This graphical presentation just shows what I was explaining, that 90% of the infections acquired at birth end up in chronic infection. So mother-to-child transmission accounts for about 1/3 of the global hepatitis B burden. So if a pregnant woman is positive for hepatitis B, we're talking about their newborn, 80 to 90% of those newborns becoming infected, and 90% of those developing hepatitis B, as I just explained from the previous graph. So currently we have a 6.5% prevalence among pregnant women, which translates, according to the current population, to about 56,160 pregnant women who are infected, translating further to about 5,824 newborns infected. And currently we have no routine screening for pregnant women, and hepatitis B infected pregnant women are unaware of their hepatitis B status, and this increases the risk for mother-to-child transmission of hepatitis B. Zambia, as a country, is aware of the dangers associated with hepatitis B, and therefore introduced the hepatitis B vaccine as part of the routine vaccination schedule in 2005. However, this starts at 6 weeks, meaning that between birth and 6 weeks, babies are at risk of hepatitis B. So what are our policy options? We have 4 policy options. The first option is to maintain the status quo, or to leave things as they are. The second option is to introduce screen and treat. The third option is to vaccinate. The fourth option is a combination of option 2 and 3. And the evaluation for this brief was based on a facility where 36,000 beds occur per year. So maintaining the status quo means that having no screening for pregnant women, no hepatitis B vaccination at birth, no ART for hepatitis B infected pregnant women, and this means that every year we will have more than 5,800 babies infected, and we will have more than 5,220 new chronic infections, and there will be no additional cost to the facility. So this is just a graphical presentation of what the status quo is. We're saying that pregnant women, when they go for antenatal, they are tested for HIV and syphilis, but they are not tested for hepatitis B, meaning that meaning that we continue having those infected newborns and so forth. Option 2 is talking about screening and treating. This means that we introduce hepatitis B screening for pregnant women during antenatal, and then the hepatitis, that is in addition to the current HIV and syphilis screening that is done. And also administer tenofovir to hepatitis B positive pregnant women to reduce the viral load so that the risk of transmission to the newborn is minimized by 40%, and this will further reduce the percentage of children who are infected to about 7.7%. This will be at a cost of $61 per pregnant woman and $4,222 per HPV infection will be averted. And we are saying that each health facility will have an additional cost of $2.1 million. Option 3, we are talking about introducing a birth dose vaccination to the newborns, giving a vaccine, hepatitis B vaccine to the newborn within 24 hours of birth, regardless of the mother's hepatitis B status. This will reduce the number of hepatitis B positive babies to 1.8% at a cost of $17 per pregnancy and a further $236 per child. And we are saying that an additional cost of $600,000 will be incurred per health facility. So this is just a schematic diagram also just showing what happens. We are saying that whether the mother is, whether a woman is hepatitis B positive or not, whether they are HIV positive or not, if their babies receive the hepatitis B vaccine, the MTCT of hepatitis B is going to be reduced to less than 2%. Then option 4 is a combination of option 2 and 3, and we are saying that it will bring down the infection to about less than 1.5% at a cost of $70 per pregnancy and $923 per child, with an extra cost of $2.5 million. So what is our policy recommendation? We are recommending option 3 because this policy offers the highest health benefits given the additional money spent to implement the strategy. But option 4 can also be considered because of the other benefits that it offers, including prevention of transmission of hepatitis B to sexual partners and the like. So further on, we also recommend that in order to implement these options, we are saying that this will reduce expensive health costs in the future. For example, currently treating a person with liver cancer costs about $30,000, but these costs are likely to increase in future. And then what are the next steps? To implement these options, we are saying that there will be need for raised communication awareness about hepatitis B. There will be need for training of healthcare workers on hepatitis B screening and treatment guidelines. And there will also be need to introduce the hepatitis B birth dose, as well as to ensure that logistics for implementing the options are available. Thank you. 1 minute. Thank you. So we are really recommending the option 3 because we are saying that this option is not coming in as something new, but it's something which is going to build on the already existing processes. For example, it will build on the BCG vaccination logistics, and also we already have tenofovir for HIV positive pregnant women, for example. And then in addition to the 3 doses that are given beginning at 6 weeks, the newborns will get the birth dose, and that will offer the protection for life.
Okay.
So our take-home message is that without the introduction of the options, we expect to see up to 9% of newborns infected with hepatitis B, and we expect even our government to spend more in treating and managing hepatitis B. Thank you.
Thank you so much. We are going straight to the next presentation. The questions will be given at the end. Please take notes. You have 7 minutes, and when I come closer to you, I'll finally cover the slides. The next presenter is Mrs. Namudi Shimbi. She's presenting on hepatitis, vaccinate, save a life, addressing the hepatitis B prevalence in the adult population in Zambia.
Good afternoon, everyone. My name is Namudi Shimbi, and this afternoon I'm tackling hepatitis B in the adult population, ages between 15 and 59. So, as my colleague earlier alluded, that hepatitis B is a highly contagious infection, and it's about 50 to 100 times more infectious than the HIV. And the virus can actually survive outside the body for at least 7 days, and it attacks the liver, which causes both chronic and acute disease. Many people are asymptomatic, however, but in some cases you find that people have yellowing of skin, yellowing of eyes and urine, and the transmission is mainly through sexual intercourse, and it's by blood and other bodily fluids. So on a global picture, we have an estimation of about 257 million people who have chronic hepatitis B infection, and only 5% of those know of their infection, and about less than 1% have access to treatment. So an estimation of 1.4 million people die every year from the disease. And age of acute and chronic infection is highest amongst the adult population. So that is the global picture of age of infection in the acute, in the adults, and also in the chronic infection. So you find that the adults actually take up a bigger chunk of the infection as compared to the adolescents, the children, and the perinatal. Okay, so what is the problem in Zambia? We have an overall prevalence of about 5.6 million, 5.6% among 15 to 59-year-olds who are HBV positive. And control strategies have focused on childhood vaccination and blood bank screening, where it only covers children under the age of 5. This was introduced in 2005, and also we've seen progressive liver diseases at the Cancer Disease Hospital. So that is the Zambian burden of hepatitis B virus, and you can actually tell from the graphs that it attacks mostly the males as compared to the females. What is our policy rationale? Zambia has adopted the WHO goal of eliminating hepatitis B virus infection by the year 2030. And this is only achievable with access to adequate preventive and treatment services. So among the National Health Strategic Plan strategies to reduce this HBV, we are to reduce the number of people susceptible to hepatitis, and also increase the proportion of people diagnosed with the disease. The first option is the status quo, which is to leave things as they are, meaning we leave the population at risk. So this means that the situation remains unchecked. The prevalence of hepatitis B could possibly be around 11.1% by the year 2030. So the second option, which is to introduce screening and vaccination schedule, This allows for screening and vaccination of HPV negative individuals that will be found between the ages of 15 and 59. Next. The third policy option will be to screen and treat individuals that are found to be positive for HPV. That is our preliminary recommendation, which is to implement both interventions, the second and the third options. This is to achieve minimum impact, because if we are going to screen and vaccinate, screen and also treat the people who are found with hepatitis, we are going to reduce the new infections in the population. Those are the next steps. We have to perform cost analysis to compare policy options, to launch a media SMS campaign for health promotion, to raise awareness, and also to introduce active surveillance of hepatitis B. What is our take-home message? Eliminating hepatitis costs money, but it saves us even more. Thank you.
Good afternoon once more. I think my task is actually simpler. Now that we've got what hepatitis is, so I'll go through direct to where it involves healthcare workers. So I've been empowered to lead you through the discussions. So this has been presented already, and I think the global picture has been given. We know that the burden is at 257 million, and in the shaded areas in heavy blue, look at where the burden is highest, and I think Africa predominates. Then when we come to the problem, one of the biggest enigmas we have in the health sector is what to do when a healthcare worker gets exposed to hepatitis. And I think the bigger issues relate to, in the acute phase, what is available, and in the chronic phase, what we do for such a healthcare worker. And we know that healthcare workers have about 10 times higher risks of contracting hepatitis B than in the general population, or because of the exposure to occupational hazards. And for sure, we know that the needle stick injuries do account for about 60% of acquired infections of hepatitis B. The other infections come through direct or indirect contact of broken skin or mucous membrane. And I think we all appreciate the versatility of hepatitis B infection. For a fact, we know that WHO recommends that all healthcare workers should be vaccinated against hepatitis B. But we know that in Zambia, that doesn't happen. And even availability of immunoglobulins for acute phase infections, as well as we know that we have tenofovir for chronic infections, the policy to guide treatment is not very strong. There we have PrEP for HIV. So, just to give a synopsis in Zambia, in terms of healthcare workers, we know that in the general population, 5.6 is in the non-prevalence of hepatitis B, and that's what the Zambia guides us. But then for zeroing in on the healthcare workers that work in this environment, we know that only 9% are vaccinated, the rest are not. And we know that per year, healthcare workers are exposed to about 1.3 needle stick injuries. Now when I was an active surgeon, I had, I think, an annual rate of about 10 needle stick injuries. And I wouldn't want to go into how many times I've taken PrEP. But that just gives you a picture. And we know that with these needle stick injuries, we've already established what it means to get hepatitis for this healthcare worker. So we know that about 62% from 23%, there's a chance of contracting hepatitis B through this means of infection, contracting disease. And I think to discuss what we consider as policy options for this very pertinent issue, I'll ask my colleague Brittany to just take us through.
So right now, the status quo in Zambia is that there's no national program for vaccinating or screening healthcare workers for hepatitis B. So we estimated that there's about 35,000 healthcare workers who are at potential risk of acquiring hepatitis B. We estimate that about 2,000 healthcare workers are currently living with untreated hepatitis B, using the 5.6 prevalence in the population to get this number here. We also think that about 3,000 of these healthcare workers have already been vaccinated against hepatitis B, so they have immunity. This is the 9% of healthcare workers that have been vaccinated. But that leaves us with 30,000 healthcare workers who are susceptible to hepatitis B infection. So we estimate that about 2,000 healthcare workers will be exposed to hepatitis B via a needle stick injury each year, and that about 33 healthcare workers will contract chronic hepatitis B each year based on this exposure. So what are some things we can do about this? Dr. Makawa already mentioned a few, but we do have a vaccine that is 92% effective in adults. We also have the ability to screen for HPV infection as well as immunity, and we can do this before someone's vaccinated as well as after they've been exposed to make sure that they're protected. We have the ability to provide hepatitis B prophylaxis after someone has been exposed, and this is 75% effective at stopping transmission of hepatitis B. And finally, we are able to treat people who have chronic hepatitis B to stop the progress of their disease and lower their viral load so they're less likely to transmit to others. So that brings us to our first policy option, which is to vaccinate all healthcare workers regardless of their history of hepatitis B infection. So in this scenario, we're vaccinating you even if you're infected, even if you're immune, or if you're susceptible. So once someone's been vaccinated, they'll be exposed to hepatitis B via needle stick injury. We'll then test to see if they have immunity, and we expect some people to be infected. These were people who had been previously infected, as well as new infections. We'll expect a lot of people to be immune based on the people we vaccinated, as well as people who were previously vaccinated. And some people will be susceptible because they didn't get all 3 doses of the vaccine, or the vaccine was not effective. These people will treat with prophylaxis and will stop the transmission of hepatitis B. So some pros of this policy option is that it's a lower budget and it's a higher operational feasibility. But some cons are that we're allowing healthcare workers who have hepatitis B to go undiagnosed, and we're unnecessarily vaccinating some people who are already immune. So policy option 2 is to test all healthcare workers for hepatitis B infection. We'll treat those who are hepatitis B positive, and we'll vaccinate those who are hepatitis B negative. So this is, again, testing for infection. If you're positive, you have hepatitis B, we'll treat you and stop the progress of your disease. If you're negative for hepatitis B antigen, then we'll vaccinate you. Upon exposure, you'll either be immune if the vaccine was effective, or if you're susceptible, we'll give you prophylaxis so you do not develop hepatitis B. The pros of this is about a medium budget and it's medium operational feasibility, and it's actually already being implemented in some hospitals here, like Onawasa, the Mine Hospitals, and a few NGOs. Con is that, again, in this model, we're unnecessarily vaccinating some people who already have immunity. Policy option 3 is the most complicated. This is where we're going to screen all healthcare workers for both hepatitis B infection as well as immunity. So when we do this, we're going to group people into 3 categories. Those who are infected, who we will treat, which is this arrow here. Those who are susceptible, who we will vaccinate, and those who are already immune, who we will not vaccinate because they are already immune and will not develop disease. So the pros is this would be the gold standard for a vaccination program, but the cons are that it's going to require a high budget and it has a low operational feasibility. There's a lot of testing platforms that need to be in place. So our preliminary recommendations are to go ahead with policy option 2, which is to test all healthcare workers for hepatitis B infection. We'll treat those who are hepatitis B positive and vaccinate those who are hepatitis B negative. We chose this model based on its perceived operational feasibility and cost, and also the impact that it will have on reducing newly acquired hepatitis B infections and identifying healthcare workers who are currently infected with hepatitis B. So in progress right now, we're actually collecting the prices to figure out all the expenditures that would be associated with each of these models. Once we have those, we're going to go into performing the cost-effectiveness analysis so we can compare these different policy options. And finally, we'll make recommendations based on this analysis. So thank you all for listening.
Now they did 288 correctional facilities in Zambia. This represents a 229% occupancy rate. So some of the factors that contribute to the spread of TB in correctional facilities include overcrowding, poor ventilation, poor nutrition, and inadequate medical care. So the question is, what are the consequences of high TB burden in correctional facilities? So some of the consequences might include transmission of the infection into the community. So this may be through the correctional facility staff that may pass the infection to their families and into the community. Or it could be through the visitors that are coming in the correctional facilities to visit the inmates, who would eventually get the infection and transmit it to the community. Or it could be former inmates who are discharged into the community. Maybe these were not adequately treated and they might end up passing the infection into the community. The other consequence of high TB burden correctional facility could be development of multi-drug resistant TB. And we know that multi-drug resistant TB is one of the public health concerns in most developing countries. So what is the problem? So currently there is no disaggregated recording and reporting mechanism of TB new cases and treatment outcomes in correctional facilities. So this can be attributed to lack of a clear policy on how to address TB issues, ensuring that issues of confidentiality and human rights are observed. So when you look at the WHO global plans to end TB by 2020, it has actually set out 3 strategies. And 2 of its strategies, the second strategy actually states that TB detection and treatment should reach at least 90% of the key population. Then the third target actually requires that 90% treatment success rate is achieved. But when you look at the Zambian situation in terms of TB detection rate and TB treatment rate, when you compare it to the general population, you find that in the general population is 32%, whilst in the correctional facility it's only at 24.5%. And when you look at the TB treatment success rate, in the general population it's 85%, and that in the correctional facility is 66%. So from these statistics in the correctional facility, you can see that we are actually far below the 90% WHO set target. So what are the policy options that we are proposing is to address the human rights concerns surrounding disaggregation of TB data in correctional facilities. And this will allow the monitoring of the level of TB detection and also the quality of TB treatment in the correctional facility. This actually builds on the Ministry of Health's strong commitment in improving TB control in correctional facilities as stated in the National TB Strategic Plan. So what are we recommending? So we are recommending that TB data that is collected from correctional facility be disaggregated. And for this to be done, there's need to have a policy. And this policy should have clear guidelines on data collection and reporting, and should also cover issues of confidentiality and data protection. Finally, there are several steps that need to be considered to develop this policy. The first thing is a policy dialogue forum should be organized to bring together the main stakeholders. And in this forum, issues to do with confidentiality will be discussed, and we'll be able to learn from best practices that are being implemented in other countries in terms of TB control in correctional facilities, and also propose the possible way forward in terms of TB control in prison or in correctional facilities. Then the other thing is to develop an action plan for the country scale up of the policy. These are our references. I'd like to acknowledge the Zambia Correctional Services, the National TB Control Program, Bloomberg Philanthropies, and WHO for their support and guidance in development of this policy.
We are quickly going to have the next presentation by Mrs. Kuta Banda Muhango. Save a cervix, save a life, reinforcing survival of cancer test and treat for HIV positive.
I realize I'm standing between you and lunch, so I will be very brief. And I would also like to mention that this brief was presented at the last forum a couple of months back, but for the benefit of people who were not there, we saw it fit to present it again. And there are some recommendations that were given last time that have not yet been incorporated in this brief. So my brief is entitled Save a Cervix, Save a Life, reinforcing the cervical cancer test and treat for HIV positive women. To give a little background, cervical cancer is the highest cause of all cancer deaths in Zambia, and more than half of all the women with cervical cancer are actually HIV positive. And only about 20% of the HIV positive women have actually been screened for cervical cancer. And globally, we rank fourth. As you can see, the age standardized rates per 100,000, Zambia is right below Cameroon on position 4. And every day, about 7 women are diagnosed with cervical cancer, and about 4 of those women die from cervical cancer. Just emphasizing the burden of cervical cancer, we're saying that the age-specific rates of cervical cancer for Zambia are actually higher than the East African region and the world statistics. So Zambia also has a high prevalence of HIV of about 15% in the entire adult women population. So the intersection between HIV prevalence and cervical cancer contributes greatly to the high incidence of cervical cancer. Sorry, this seems very hard to see. My apologies for that. But this basically summarizes the 2 policy options that I'm proposing. The first one is the no intervention, which is the status quo, the way it is right now, with the 20% HIV positive women being screened. So this graph basically summarizes how many women will be VIH positive, how many women are found with cancer, how many women are treated under the test and treat programs. And we are proposing an opt-out strategy for cervical cancer screening of up to 90%. So this graph, it's a little hard to see, but it also just shows at 90% how many women will be VIH negative, VIH positive, how many will be treated under the screen and treat, and how many will actually have the cervical cancer. So that goes into my next slide, which talks about the 2 policy options. The status quo, where we do nothing and just let it be as it is. And the second option, which is a test and treat program for the HIV positive women at different levels. So there's at 45% and at 90%. So we're basically saying this policy option, it requires screening the women who are HIV positive and reinforce the already existing guidelines. So we're not introducing something new. The HIV treatment guidelines already provide for screening of all the HIV positive women. So what are we saying? What we're basically saying is routinely screen women, HIV positive women, as described in the HIV treatment guidelines. And why do we think this would work? We're saying that this opt-out strategy for screening, cervical cancer screening, in 1 year at 45% and 90% would increase the number of women who are screened and treated under the screen and treat program to about 37 and 80% respectively. And feasibility, we're saying that this option is medium to high feasibility. Again, my apologies, this may not be very clear. This table is crowded, but this table basically summarizes the different policy options and the benefits. I would like to draw your attention to the first row, which says the number of unscreened HIV positive women. So approximately that is the number that we have, over 600,000 women. And so we are saying that at status quo, 20%, opt-out at 45% screening, and opt-out at 90% screening. This is all in 1 year. So just to quickly go to the last row. So the last row is showing the number of unscreened HIV positive women who are at risk of developing late-stage cervical cancer. So what we're saying is, at the status quo, at the 20% level of screening, the number of women, HIV positive women, at risk of developing late-stage cervical cancer is between 98,000 to close to 200,000 women. That is the HIV positive women. And if we increase the screening to about 90% of the HIV positive women, the number of women who are left at risk of developing late-stage cervical cancer comes to only about 12,000 to 24,000. So this graph looks at both the number, the effect, which is the number of women, and the cost for each option. So at 20%, the numbers in here have been swallowed. Somehow they are not here. But basically, there we have the policy briefs that are printed out, the Word document, and this graph is trying to show that at the 20% screening that we are at, which is this red dot, it shows that the numbers are in the brief. Thank you. So it shows that for about 120,000 women, we are spending approximately 13 million. So this cost is inclusive of the VIA test kits, the cost of medical care, including the cancer care. So this model takes into account all of these costs. So in the first year, we are saying that the cost will be quite high to test and treat women at 90%. But as the years go by, the cost reduces because you would have already found the VIA positive and you would have already treated them under the test and treat. So the cost of treating for the cancer at CDH reduces. So in conclusion, what we're saying is that the opt-out testing or opt-out strategy for testing HIV positive women at 90% can potentially decrease the number of estimated HIV positive women at risk of developing late-stage cervical cancer by approximately 160 women, which is about 28% of all the HIV positive women. Recommendation, the limitations, acknowledgement, the take-home message: we do not need to cure cancer if we can prevent it. Thank you.
So we've had some options that are there for us to address TB in the correctional facilities. We've also had options that are available as we address cervical cancer. I'll take 2 rounds of questions. I see that there's a hand already here, and the director, and then there's the lady. I think let me take these 3, then we move on. Ladies first. Over to you, ma'am. Yes, you?
My name is Margaret Casaro from UNC GPZ. I have a question to Peter. The 90% intervention, I suppose that's a recommendation. I'm just wondering, with those fantastic numbers, is that a feasible thing that can actually be done?
Yes.
All right. My name is Raymond Hamonga from Zambia National Public Health Institute. And the question goes to the first presenter. You did speak about the aspects of occupancy rates of about 200% in prisons. And then you also highlighted the problem of integration of the data that's not filtering through to policymakers to implement TB control. Now my question is, which one comes first? Would you say that if we keep the occupancy rate at 200+%, that is still fine if we sorted out our data, or we need to sort out the occupancy rate problem first? Thank you.
Thank you, Mr. Tanko.
Yes, I'm just imagining that I'm a director in the ministry and they come and make that innovation. And this means that I use the screening program. So apart from the costs, what other critical elements are you going to look at in terms of a good screening program? What are the other things which you convince me as a policy maker that yes, let's introduce a screening program?
Thank you for those questions, and since she's already standing up, we could begin with you. Ready? Yes. So, I'll take the question from Dr. Mkonka, Dr. Monga's question answered next, and Madam Kasaro's question. Go ahead.
So I think the questions are actually a little related in the sense that asking about the feasibility, it's a question that came up even in the previous presentation. We have Dr. Sharon Kapambwe, and last time we had Dr. Tina Chisenga as well. So one of the recommendations is to have the HIV and the cervical cancer unit speak to each other, because if we're saying screening HIV positive women, we have a lot of facilities nationwide that provide HIV care. So the using of some of the HIV facilities to do the cervical cancer screening, if there is that joint or that collaboration between the two departments or units, it could be possible. But I'll leave Dr. Sharon to add if she has anything more to add. And then your question, Director, what more? So I think I would link that question to the question of the feasibility. So I think I would come to you with the numbers to show this is the number of women that would potentially be served from cervical cancer at this cost. But not only that, I would also bring up the working together of the cervical cancer and the HIV. In terms of resources, if we have the cervical cancer tapping from some of the resources that are already available for HIV, that reduces the cost to the Ministry of Health. So for instance, in the cost, we took into account the building, if at all you are building a new building, the equipment, but if the HIV team already has a building, it means that the cancer team does not need to have a cost for the building. So the cost reduces at large when there's this integration of different programs.
Thank you. Director has a follow-up question. I will allow that.
But I wanted to do a little bit more research on it. Yes, it's a good attempt, but you can do more. Usually screening program, what we do first is to check whether what you want to be screening for, what is the burden of the disease. Is it a major problem for the country? Secondly, you must know whether there is an intervention. Okay. The third is whether you are able to pick it locally or whether in situ before it can spread. Then of course the issue of race over the cost can be agreed. And fifth, there must be technology easy to deal with it. And the sixth must be acceptable to the community or the people are going to provide. So you need a bit of that, then you come and convince me that yes, let's introduce a screening program for